Hey students, it's Dr. Kessler and you are listening to the lecture for Chapter 13, Fluid and Electrolytes, Balance and Disturbance. It's quite a long chapter with a lot of information, so take breaks as you need to. This will probably be the longest lecture that you have from me. I couldn't really figure out a good way to break it up though. So your objectives, you should be able to differentiate between osmosis, diffusion, filtration, and active transport. You should be able to describe the roles of the kidneys, lungs, and endocrine glands in relating to the body's fluid composition and volume. Plan effective care of patients with fluid volume deficit, fluid volume excess, sodium deficit and excess, as well as potassium deficit and excess. Describe the causes, clinical manifestations, management, and nursing interventions for all the electrolyte imbalances. Explain the role of the kidneys, lungs, and chemical buffers have in maintaining acid-base balance, and compare metabolic acidosis with alkalosis as well as respiratory acidosis with respiratory alkalosis, as well as knowing the causes, clinical manifestations, diagnosis, and management. So as far as fluid volume in the body, it varies based on gender, age, and body fat. If you are younger, you are going to, in general, have more fluid volume than the older population, and proportionally, men have more fluid than women. Those who have thinner frame generally have more fluid than the obese, and that's because the fat cells carry little fluid. All body fluid is located either in the intracellular space or the extracellular space. 2/3 is intracellular, and it's located within skeletal muscle mass, mainly. And then 1/3 is located in the extracellular space, and that can be intravascular, which is within the blood vessels. This includes leukocytes, erythrocytes, plasma, and thrombocytes. It can also be found in the interstitial spaces, which is the space surrounding the cells. That does include the lymph system. And then it can be transcellular. And that would be, for example, cerebrospinal fluid, pericardial fluid, synovial fluid, intraocular or pleural fluids, and then your sweat and digestive secretions as well. The body will do its best to maintain this equilibrium of fluid, to maintain homeostasis. So whenever you don't have that 2/3 to 1/3 ratio, you can have an imbalance, your body will respond. When fluid is lost from the extracellular space into a space that does not contribute to the equilibrium between the intracellular and extracellular fluid space, it's called third spacing. So that's whenever fluid isn't in either ICF or ECF, so it doesn't contribute to the equilibrium. Because of this, homeostasis is disrupted. Fluid volume deficit or hypovolemia is generally present, and that is due to the lack of intravascular fluid. The kidneys will in turn receive less blood volume, and this will decrease urine output. Okay, sorry about that. Homeostasis, we're going to back up just a few bit. So with third spacing, it disrupts homeostasis. You do go into a state of hypovolemia or fluid volume deficit. That's due to the lack of intravascular fluid. Because of this, the kidneys receive less blood, and this will decrease urine output in an attempt to compensate. Other signs, and we'll go over hypovolemia, but you will have increased heart rate, decreased blood pressure, decreased central venous pressure, edema, increased body weight, and imbalances of fluid intake and output. So whenever you do I&O, you will definitely see a difference. Hydrostatic pressure is the pressure exerted by the fluid on the walls of the blood vessel at the arterial and venous ends of the vessel. Hydrostatic pressure and osmotic pressure are opposing forces, so they actually will push against one another. Therefore, the movement of fluid will depend on the differences in these two pressures. So if one's higher and the other's lower, then you'll have movement of fluid based on that. Osmotic pressure is the amount of hydrostatic pressure needed to stop the flow of water by osmosis, and this is determined by the number of solutes. Osmosis is the process of moving the solvent particles across a semi-permeable membrane from a dilute solution to a concentrated solution in an attempt to equalize the concentration. Osmosis occurs when two different solutions are separated by a membrane, and it is impermeable, which means that it has little holes in it. The fluid will shift through the membrane from one region of low solute concentration to the region of high solute concentration. So if you have pure water on one side of a container and salt water on the other side, they're separated by a semi-permeable membrane. The water is what will move across the membrane in order to equalize. And the salt stays where it is. You just have a movement of more pure water over to where there's less pure water in an attempt to equalize. That's osmosis. Diffusion is different. With diffusion, the solutes themselves can move from an area of higher concentration to an area of lower concentration. So room deodorizers, high concentration getting out into the air, which is the lower concentration. The exchange of oxygen and carbon dioxide in the alveoli. That's another example of that's how that exchange occurs. And that's another example of diffusion. The tendency of sodium to move from extracellular fluid compartments where the sodium concentration is high to intracellular fluid compartments where the concentration is low would be another example. Movement from water and solutes occurring from an area of high hydrostatic pressure to an area of low hydrostatic pressure is called filtration. And then with active transport, energy is involved. So energy is expended so that you can have movement against a concentration gradient. So you have an area of higher concentration and an area of lower concentration, and you're actually wanting to add to the area of higher concentration. So if you think about potassium inside the cell, when you're trying to pull more potassium from outside the cell into the cell, you need active transport for that because there's more molecules in the intracellular fluid than there is in the extracellular fluid. And the reverse of that is true for sodium. More fluid or more sodium's in the extracellular space, and so it needs to be pulled from the intracellular fluid out to the extracellular. And that is done by the sodium-potassium pump. You do intake and output when you're looking at fluids, and that is called or referred to as gains and losses. So if you have a gain, anything that you take in, that's a gain. So you're drinking fluids, you're eating, if you're on a liquid diet, if you have soup, anything that has liquid in it, you're consuming that, you're taking that in. And then you should be excreting that through the kidneys. Your intake and output by the end of a 24-hour period should be about equal. So what you take in, you should be able to void or excrete out. As far as the kidneys are concerned, you should lose about 1 milliliter per kilogram per hour. That's what the kidneys should be able to do. You will also sweat, you can cry, you can be in an area that's really hot and then you'll sweat more, and those are called, that's sensible loss. You can also be in an area where you're exercising and you're sweating a lot, and so you can lose some fluid there. when you burn yourself, you will lose fluid there as well. And we do have a unit on burns, and we'll go into that more. Just from breathing in and out, you can lose some fluid. If you have an increased respiratory rate, you'll lose more than if you have a suppressed respiratory rate. And then you can lose fluids from your GI tract, especially if you have loose stool, diarrhea, vomiting, and then if you have fistulas. You do have to take into account patient population. The geriatric population has higher incidence of dehydration. Don't confuse dehydration with hypovolemia. There is a difference in the two. But dehydration in the elderly is common, and it results because of decreased kidney mass, decreased GFR, or the glomerular filtration rate, decreased renal blood flow, decreased ability to concentrate urine, and the inability to conserve sodium, decreased excretion of the potassium, and that's done by the kidneys, and a decrease of total body water. Age-related thinning of the skin and loss of strength and elasticity of the skin also play a part. So you have to take all of that into consideration. Tenting is not a reliable way to check for fluid volume deficit in an elderly person because of the loss of elasticity. You can pinch them at their sternum and it might stay tented, and it has nothing to do with their fluid volume status. It has to do with the fact that their skin has just, it's not as elastic as it used to be because of their age. There are two types of fluid volume imbalances. You can have fluid volume deficit or hypovolemia, and then fluid volume excess, which is hypervolemia. Okay. Hypovolemia can occur alone, or it can occur with other imbalances, but it occurs when the loss of extracellular fluid exceeds the amount of water or fluid intake. Do not confuse dehydration with hypovolemia. In dehydration, only fluid is lost, and that leaves a higher concentration of sodium. In hypovolemia, both fluid and electrolytes are lost. As far as signs and symptoms, you'll have tenting, oliguria, prolonged capillary refill, concentrated urine, flattened neck veins, and that's because of the decreased volume of the intravascular fluid, dizziness, weakness, thirst. They can become confused. Have elevated heart rate, orthostatic hypotension, muscle cramps, sunken eyes, elevated temp. It will be low grade but still elevated from their norm. They'll have cool, clammy, and pale skin, and that's because of the decreased perfusion. Poor cap refill is also because of decreased perfusion. As far as labs, an H&H will be higher because of the increased plasma concentration. So whenever you do serum lab tests, they're looking at the plasma. And if it's more concentrated, if it's thicker, then you're going to have higher H&H. You'll have elevated BUN and creatinine. BUN and creatinine ratio, which is normally 1:1, will not be proportionate because the BUN will be elevated higher than the creatinine. If you do a urine test, you'll see specific gravity increased because you'll have increased concentration. And this is a way to figure out, based on fluid loss, like how your body's going to respond, what signs and symptoms you're going to have. Just a really neat flow chart if you're a visual person. As far as the nurse, you're going to do what you can to minimize fluid loss. First, you're going to do your assessment. Do a history of present illness. You're going to do a complete head to toe physical exam, look at their labs. You can administer oral fluids if it's not severe and if they can take in oral fluids. If they cannot, then you'll want to start an IV and do parenteral fluids. You'll start with isotonic solution, and you want to start with that because because it most resembles their intravascular fluid. And that would be normal saline or lactated ringers. Once they're normotensive, you can switch to a hypotonic solution so that they're not getting too much sodium. Okay. You never, ever, ever just give sterile water through an IV. IV solutions contain dextrose and or electrolytes mixed in various portions with the water. Giving pure electrolyte-free water that has no glucose in it will actually cause the red blood cells to burst, and the patient will expire. They won't survive that. And then if there is a cause, you want to address the cause. As far as fluid volume excess, isotonic expansion of the extracellular fluid is caused by the abnormal retention of water and sodium in approximately the same proportion in which they normally exist in the ECF. Because of this retention of body substances, along with increased sodium, the sodium to fluid ratio will basically remain the same. Let's see, examples of fluid overload or when you might see fluid overload. Anytime you have diminished homeostatic mechanisms. So heart failure, kidney injury, if you have liver cirrhosis, if you drink or consume foods or fluids that have a lot of sodium in them and your body absorbs that, you can have fluid volume excess. And as far as treatment goes, you're going to watch their intake and output. You might have to put them on fluid restrictions and actually restrict the amount of fluids so that they're putting out more than they're taking in. When you check their labs, their hematocrit and their BUN will be low, and that's because the plasma is diluted. Generally, these patients will have low protein intake. They also can be anemic. Sodium levels can be decreased, especially if you have chronic kidney disease. And the urine sodium levels can be increased. And that's because the kidneys are trying to compensate by excreting more volume, more fluid volume, and then they're also trying to get rid of the excess sodium. Okay. If you do a chest x-ray, you will most likely see pulmonary congestion. If you listen to their lungs with fluid volume excess, you're going to hear crackles. They will complain of being short of breath. You'll notice that they have dependent edema, and it most likely will be pitting. You will give them medications and monitor their response to the medications. Most likely, you'll be giving them diuretic therapy. And you can give them parenteral fluids, but you need to watch the fluid intake to make sure that they don't have fluid excess. You want to do education on fluid restriction if you have fluid restriction, and then also sodium intake. So you want them to limit their sodium intake. What is high in sodium that they should avoid as far as foods? Obviously, don't add table salt to the foods, but what foods inherently have more sodium in them, as well as drinks, because sports drinks, soda, those have a lot of sodium in them as well. People don't always think about that. And then you want them to rest. You can do dialysis if their kidneys are not functioning and are not able to get rid of the excess fluid, but that's an extreme measure. That's something you do at the very end. You do want to monitor their intake and output, and you also want to do a daily weight.